Hello again, folks. Here we are. The snow is falling. The fire is made in the fireplace. The dogs are all fed. We're ready to go. We're going to take a look at some of the acute neurologic disorders. Our list here covers the whole lesson, but some of the things you're going to work on in the reading assignments, the Guillain-Barré and TIA and tremors are more thoroughly covered there, although we'll touch upon a couple of those here in these videos. Our plan has all fallen apart because of the blizzard, so I'll go ahead and start with some dizziness kind of cases. Let's start with an elder who presents with a chief complaint of dizziness. Became dizzy last evening in the bathroom, lost her balance, fell to the floor, sustained a facial injury. She denies loss of consciousness. She does have occasional dizzy spells, but this has been the worst yet. So she says, she has some mild dementia, she's hypertensive and osteopenic, lives in a mother-in-law apartment adjacent to her daughter's home. So even without starting to ask her some more questions and really probing in terms of some differentials, I'm already kind of interested by a few key facts in this scenario. I'm interested in the fact that she's had episodes like this before, so I'm thinking, this is kind of an acute on chronic situation. I'm concerned about the fact that she did sustain an injury to her face, so she may have kind of two things going on today in terms of a new traumatic brain injury as well as the dizziness as the precursor. I'm trying to sort out, however, what happened and why she fell. Quite honestly, most often what people come in complaining of is, oh, I fell. And then you probe and ask them, why did you fall? And you find out that it's because they lost their balance and they felt dizzy. What I do note is she has mild dementia, so I probably want some family help with some of the history. She is treated for hypertension, so that's important to me. And I'm worried because she's osteopenic and that may impact her, her injuries to her facial bones. She does live in a mother-in-law apartment adjacent to her daughter's home, so she has some supervision and assistance. But I always wonder about such environments, you know, what are those environments like? And that's kind of an aside for a later set of questions. So your questions, I'm sure you can formulate a number of those. I liked the differential diagnosis flowchart in the textbook on page 82, and it helps give me some ways of asking questions that will guide me into the various buckets, if you will, of differentials. Of course, you want to find out kind of when this started and how often it is occurring, what was it like today, how long did it last, all of those things. Most importantly, I'd say in terms of this particular complaint of dizziness, you want to find out what the precipitating factor is, or in the patient's language, how did this come on, or why did this come on, or what do you think? And so in her case, most likely she will tell you that that the dizziness is worse. She stands up from laying down or sitting and she gets a dizzy spell. She may also tell you that it will, she gets the spells when she is fatigued or after a long day out with family where she hasn't drunk anything to keep her fluids up, and it leads you down the road of possible dehydration. So you're always thinking as you're asking these questions, which of my differentials might be a possibility. In this case, most importantly, it's not only to figure out what precipitated the event, but also what is the characteristic. This is one of those complaints that you really have to tease out the characteristic. Is it dizziness in terms of feeling lightheaded, which is probably her complaint, and we'll probably go with that with her, and you want to be sure be sure that she is not vertiginous or having vertigo, which is the spinning sensation. So not having vertigo, feeling lightheaded. You also want to really carefully probe in the case of dizziness whether there was any pre-syncope or syncope, fainting. So did she feel like she was going to faint? Did she feel as though she did faint? And this is not only talking about the fact that she hit her head and she might have lost consciousness from a head injury, but the precursor. Did she feel as though she was fainting? Because those sensations, syncope and pre-syncope, tend to go more with worries about cardiac until ruled out, especially in this elder population. A sense of lightheadedness, on the other hand, where she doesn't really feel that, she just kind of loses her balance, kind of leaves you down the neurologic road or electrolyte imbalance road, such as dehydration, or in some cases actually hyponatremia from overhydration in the case of a person who has renal or hepatic dysfunction. So there's some of those kinds of cases. But again, that's an electrolyte imbalance. So right into the other questions that you want to ask, not only, of course, teasing out all the characteristics and the timing and onset and duration and all those things of the chief complaint, but what else is going on with her? What are her medications? Of course, you want to know her names of her meds and her doses, and is she taking them, and looking those up and being sure that they don't have any side effect. If she's treated with drugs for hypertension, all of them have the side effect of dizziness or lowering the blood pressure. So we think about that as one of our first things, is the medication side effect. Secondly, other parts of her history. We know her living situation in terms of social history. What about substances? Don't be thinking because she's this age that she doesn't sip wine all day long or goes over to her kid's house and has some alcohol or other substances. So we want to tease that out and be sure we don't have other causes of that dizziness. In her case, her plausible differentials, we really are probably going to think of common things happening commonly, such as we already mentioned, dehydration, possibly electrolyte imbalance. The cardiac thing is something we really want to think about with her, cardiovascular, I should say. And in this, I would group, your dysrhythmias, hypotension, and so forth. Things also kind of indirectly related to that, like anemias. Again, very common in the elderly, especially, B12 deficiencies with aging and other anemias of chronic disease particularly. We already talked about electrolytes and dehydration, of course, being very common in elders who lose their thirst drive and will often withhold fluids from themselves, especially in certain social situations, or if they're worried about urinary incontinence. For your exam, I think you already know what you need to do. Obviously, you need to take her vital signs because vital signs are vital. And we're going to be, of course, focusing on cardiovascular vital signs. There is a controversy over the use of orthostatic signs, having her stand up and wait a minute and then take her blood pressure and pulse being more sensitive to volume changes as you stand. Sometimes I think it's still a little bit valuable, but there are other cues and clues to her hydration status that are probably more accurate. But we do want to listen to her heart for any dysrhythmias or valvular issues that we might hear, and certainly checking her hydration status in terms of her skin exam and mucous membranes. Of course, you're going to do the full neuro exam, all cranial nerves, all neurologic tests that you were taught in advanced assessment. So this is the time to use those skills and do all of them. I would say all of the complaints in this chapter, I pretty much would expect a fairly thorough neuro exam for people. And that helps us rule out some of the kind of more ominous neurologic causes. We've talked about cardiac being a big one in elders in terms of dysrhythmias or hypotension. In terms of neuro, we're talking big time problems with, big problems, strokes and tumors and things like that. And if our neurologic exam is abnormal, she's going to be referred on for further testing there. But if it's normal, we can, ease ourselves into thinking that this is probably something fairly common, like electrolytes imbalance, dehydration. And never forgetting, like they say in the flow chart on page 82, that anxiety and depression can add to some of these sensations, hyperventilation being pretty common in an anxious elder patient who might be scared on her own. So after examining her and kind of thinking through our differentials, we want to move on to a plan. And most of our plan initially, of course, is going to be further kind of diagnostic workup. And in her age group, I probably would do a couple of basic things, even if everything looks pretty good. I probably would draw a complete blood count looking for anemias. I'd probably draw a comprehensive metabolic profile looking for her sodium levels, making sure they're adequate, looking for her potassium, make sure that's on target, not high or low, and looking at her BUN and creatinine in terms of hydration and renal function. Of course, her liver functions are important, believe it or not. People with liver failure, it does affect the kidney function, and we get these hyponatremic states. It's kind of complicated, but not impossible, especially in this elder population. So we want to look at those things probably. Maybe an EKG with a rhythm strip to look for dysrhythmias. You know, especially if there's a sense that this is a cardiac thing, we want to do a further workup. And she may need further workup with cardiology in terms of echoes and things like that. If she's been syncopal, she's probably got to go in for some more imaging, and that involves emergency referral for CT, etc. Obviously, if you have any abnormalities in the exam, such as unilateral weakness, etc., suggestive of stroke or TIA, she needs to go in for more workup. But generally speaking, these are pretty straightforward. I'm going to pause here and call this a quick TED Talk, and we'll open up the next slide set with the second case and talk a little bit more about other kinds of dizziness.